Good morning, everybody. I talk about therapy and children with X-linked hypophosphatemia. Definitions. X-linked hypophosphatemia is characterized by increased secretion of fibroblast growth factor 23, FGFG23, which leads to hypophosphatemia and consequential rickets, osteomalacia, and skeletal deformities. We investigated Burosumab, a monoclonal antibody that targets FGFG23 in patients with X-linked hypophosphatemia. X-linked hypophosphatemia, a disorder of renal phosphate wasting and the most common hereditary form of rickets, is caused by loss of function mutations in the gene encoding phosphate regulation endopendized homolog X-linked, which results in excess circulating fibroblast growth factor 23, excess FGF23 impaired renal phosphate resorption, which leads to hypophosphatemia and decreases the synthesis of the active metabolite of vitamin D. Chronic hypophosphatemia leads to rickets and osteomalacia, which often result in student growth, lower limb deformity, pain, and physical dysfunction that can limit daily activities.
X-linked hypophosphatemia is an inherited disorder of renal phosphate wasting that leads to rickets, osteomalacia, stunted growth, and ultimately lower limb deformity, pain, and physical disability. It's caused by a genetic mutation leading to excess production of fibroblast growth factor 23, which impairs renal phosphate reabsorption and vitamin D synthesis. An open-label Phase 2 study evaluated the efficacy and safety of Burosumab, a recombinant human monoclonal antibody against FGF23, in children with X-linked hypophosphatemia. 52 children 5 to 12 years old with X-linked hypophosphatemia and active rickets were randomized to receive subcutaneous Burosumab every 2 or every 4 weeks, titrated to achieve low normal serum phosphorus levels. Follow-up measures were assessed after 40 and 64 weeks. By week 40, the mean radiographic Thatcher-Ricketts severity score decreased from a baseline of 1.9 to 0.8 with every 2-week dosing, and from a baseline of 1.7 to 1.1 with every 4-week dosing, and the improvements persisted at week 64. Mean serum phosphorus levels increased after the first dose of Burosumab. Over half of the patients attained normal levels by week 6, and the every 2-week dosing maintained stable levels through week 64. The mean standing height Z-score increased overall, patient-reported pain was reduced, and physical ability improved. Most adverse events were mild to moderate in severity. The authors conclude that for children with X-linked hypophosphatemia, Burosumab improved renal phosphate reabsorption and serum phosphorus levels, reduced rickets severity and pain, and improved growth and physical function. Full study results are available at nejm.org.
Applications in medicine. Conventional therapy for X-linked hypophosphatemia consists of multiple daily doses of oral phosphatic salts and vitamin D, metabolized or analogous as replacement therapy. This treatment, which has been in place for approximately 4 decades, transiently increased serum phosphorus levels. However, it is associated with incomplete healing of rickets, residual skeletal deformity, persistent short stature, gastrointestinal side effects, and rates of metabolic and endocrine abnormalities such as hypercalcinuria, nephrocalcinosis, and hyperparathyroidism. Burosumab is a recombinant human IgG1 monoclonal antibody that targets FGF23 in phase 1 and 2 trials involving adults with X-linked hypophosphatemia. Treatment with Burosumab administered at dose of up to 1 mg per kilogram of body weight every 4 weeks improved renal tubular phosphatic reductions, thereby increasing serum phospharum to normal levels and increase serum 1 to 25 deoxyvitamin D levels. Here we report the results of a clinical trial that evaluate the efficacy and safety of Burosumab in pediatric patients with X-linked hypophosphatemia.
Burosumab is a monoclonal antibody that inhibits FGF23. Burosumab is now approved by the FDA for the treatment of X-linked hypophosphatemia, XLH, both for children and adults. Also, it has been approved by the EMA for children. In this meeting, Kamenicki and colleagues studied the interest of Burosumab at a dose of 1 mg per kilo in adults with XLH, so patients received for 24 weeks either Burosumab or placebo, and after 24 weeks, all the patients were treated by Burosumab. After 48 weeks, compared with patients who first received placebo, for those treated by Burosumab, there were improvements in serum phosphorus, which was the primary endpoint, but also an improvement of pain, stiffness, physical functioning assessed by the WOMAC, and fracture, pseudofracture healing.
Pros and cons. Pros. Inhibition of FGF23 activity with Burosumab and recombinant human IgG1 monoclonal antibody was associated with an increase in renal tubular phosphate resorptions and the correction of hypophosphatemia in children with X-linked hypophosphatemia. The improvement in phosphato metabolisms corresponds to a decrease in the severity of rickets. The healing of rickets probably contributed to the current improvements in grow up and physical activity and reduction in pain. Cons. One patient who received Burosumab every 4 weeks has hospitalized for serious adverse events of fevers and myalgia, both of which were assessed as being moderate in severity and possibility related to Burosumab. The fever resolved within 24 hours after onset. The myalgia resolved within 8 days, and the patient continued to receive treatment without recurrence of a similar event in the every 4 weeks. Dosing grow up and injection site reactions. These reactions were considered to be mild, were limited to the skin and lasted no more than 1 or 2 days. Other common adverse events across the 2 dosing groups were headache, gout, nasopharyngitis, and pain in an arm or leg. Issue applied in Ecuador. The Institutional Review Board at each participant site approved the protocol available in NAJM.org. Parents or guardians provided writing informed consent for the appropriate. The patient's assent was obtained before participation and external data and safety monitoring. COM9 monitored patient's safety. Conclusion. In children with X-linked hypophosphatemia, treatment with Burosumab improved renal tubular phosphate resorption, serum phospharin levels, linear growth, and physical function, and reduced pain and the severity of rickets. For more than 40 years, treatment for X-linked hypophosphatemia has consisted of multiple daily doses of oral phosphate salts and active vitamin D. This approach is often difficult to maintain, particularly in younger patients, owing to the burdens of multiple daily doses, parenteral surveillance, and suboptimal phosphate preparations. The limitations of conventional therapy and evidence by the persistence of rickets observed in radiograph obtained and screening in this trial despite the patient having received therapy for X-linked hypophosphatemia and academic specialty centers for multiple years. By targeting ancestral pathophysiological defects in X-linked hypophosphatemia, Burosumab improved phosphato homeostasis and decreased the severity of rickets.
Hypophosphatemic rickets is a disease that always interested me. I started my training in '81, so it's now 30 years. It is not uncommon. We have about 20-25 children with this disease here at Children's Mercy Hospital between endocrinology and us, and there is excellent collaboration between the two sections. And the treatment, I would say, for the past 40 years was quite standard, providing very large quantities of phosphate and vitamin D. And this treatment, if it starts at an early age, is quite effective. The problem is that many of the patients develop side effects to these two medications. So that's the main problem. So it's a very delicate balance, giving the optimal dose of the medicine on one hand to achieve the therapeutic goals of correcting the rickets on one hand, while on the other making sure that the patients do not develop the side effects, the complications. And keep in mind, these side effects are being caused by us, the physicians. We are those who prescribe the medications. These side effects do not appear in untreated patients. And these side effects the two more common ones are either development of calcifications in the kidney, and you can see it very clearly on ultrasound, or development of complication of the parathyroid glands, hyperparathyroidism. My goal over the year was first to convince the scientific and community and also physicians that especially the complication in the parathyroid glands is due to the treatment. It took me a long time, I would say 20 years, to go to conference after conference and show my research results time and again until it became accepted. Now it's in the textbook. 6-7 years ago, a new medication appeared in the market. Again, this medication is designed or was made again for patients, mostly adults, with chronic renal failure to protect them from the complication of secondary hyperparathyroidism. But the mechanism is the same also in patients with hypophosphatemic rickets. About 3 years ago, we published the first paper, which is now very well recognized. And this was a short-term study in which we tested the kids only for 2 days and definitely demonstrated that the medicine has great potential in treating these patients. And since then, we have proceeded with long-term study, and the results are very encouraging.
Thank you for your attention.